Hello, I'm Chance Nicholson. I am a psychiatric nurse practitioner and faculty here at UAB. I teach in the psychiatric nurse practitioner specialty track. I also have a faculty practice at the VA 2 days a week. These little videos are designed to complement the PowerPoints and the readings of your book. They are not designed to supplement your reading in any way. Just trying to clarify a few points and maybe just add a little bit more depth to the material that you're reading. They're going to be pretty short in length, so hopefully there'll be one posted for every single chapter, probably about 10 or 15 minutes in length. This one here is based on antipsychotics. The assumption when making these videos is that you guys have done the reading and have looked at the PowerPoints. So I'm not going to spend a whole lot of time talking about those preliminary details. So to start this off, just trying to give you a perspective of maybe when and why you would see some of these medications in an outpatient setting, and sort of to maybe highlight some chemical differences in terms of how they function, and when you may use them, or what type of symptoms you might use them for. So very briefly, I'm going to cover first generation and second generation classes, which you have in your PowerPoints. So review those. So first generation antipsychotics, or what's known as conventional antipsychotics, they block receptors for dopamine in the central nervous system. They cause serious movement disorders known as extrapyramidal symptoms. Really, first generation and second generation both cause these. First generations tend to have a higher incidence, which I will discuss why in a few moments. Two examples of first generation are Haldol, which is a high-potency antipsychotic, and then Thorazine or chlorpromazine, which is a low-potency. And really all low and high means is low means that it requires more to cover the same amount of receptors. So with low potency, you're going to see higher dosages. For instance, in Thorazine, you can have as much as 2,000 milligrams. It's probably dangerous, but I've seen it before. Low potencies have more alpha-1 adrenergic effects. They cause, which that causes hypertension, orthostatic hypertension, and also have more histamine or H1 reception. So that's why with those in particular, you get heavy sedation and increased appetite. Those are some of the side effects, or some of the reasons why they don't use them as much anymore, except for in inpatient capacity. In relation to second generation antipsychotics, they produce only a moderate blockade of dopamine receptors, really a stronger blockade for serotonin versus the first generation. They have fewer EPS, and they're more effective against what we would call the negative symptoms. So in schizophrenia, you have positive symptoms, which are things that are there which shouldn't be there. So that's hallucinations, that's delusions, paranoia. For negative symptoms, it's things that are supposed to be there and they're not. A useful way to think of them are these symptoms, and they're denoted with an A, which essentially means without. So anhedonia, avolition, apathy, acommunicative, inertia, poverty speech, asocial, in this case, sort of social withdrawal. So, we should have pleasure, we should have the ability to make decisions, we should be feeling emotions, we should be able to communicate, we should have energy. So that's what I mean by negative symptoms. Now, the reason why I bring that up is because when you're actually prescribing first generation and second generation antipsychotics, second generations tend to be better designed for those negative symptoms, whereas first generations tend to focus primarily on the positive symptoms. So if you have someone that's fluidly psychotic, someone that may come in acutely psychotic from schizophrenia, or maybe acutely psychotic on crystal meth or cocaine, it may be of interest to use a first generation antipsychotic versus a second. So why does this work? I mean, in the brain, why does this happen? Where's the discrepancy or the difference? So positive symptoms occur in the mesolimbic pathways of the brain. Negative symptoms occur in the mesocortical pathways of the brain. The nigrostriatal tract is responsible for the extrapyramidal symptoms, and then you have the tuberoinfundibular tract, which is colloquially referred to as the boob tube, is responsible for the increases in prolactin, which give you the sexual side effects that you don't really want regarding antipsychotics. There's an inverse association between dopamine and prolactin, so as dopamine decreases, prolactin goes up. Also, with a decrease in dopamine, you get a decrease in testosterone. And so just kind of keep that in mind. So when you're using antipsychotics, the design is to actually reduce dopamine, because in schizophrenia, the pharmacotherapy theory is that schizophrenia is caused by an excess of dopamine, so you're trying to reduce that. So by giving these medications, you're reducing dopamine in those 4 tracts that I just mentioned: mesolimbic, mesocortical, nigrostriatal tract, and the tuberoinfundibular. All right. So first generation antipsychotics primarily reduce dopamine in the mesocortical and the nigrostriatal tract. They don't really affect the mesolimbic, which is why they don't have a lot of utility in schizophrenia with negative symptoms. But the reduction in the nigrostriatal tract is what gives it a higher incidence of EPS. It's the same pathway that's involved with Parkinson's disease. So when you hear people say EPS or pseudo-Parkinson's, that's why. It's because it's the same brain area and pathways that are being interrupted. For instance, levodopa actually increases dopamine in the nigrostriatal tract. So what do we do for EPS symptoms when they actually arise? So you've heard of anticholinergics before: Benadryl, cogentin, or benzotropine. And what this does is it does exactly what it says. It's anti-acetylcholine. So we know that acetylcholine is a memory, learning sort of neurotransmitter, but it also helps with motor movement. So when you're given medications, in particular antipsychotics, and you bring dopamine down, what you're doing with the acetylcholine, because of its properties with motor, is you're bringing it down to match the dopamine, and that's why you can reduce the EPS. So really, the lower the dopamine goes down, the lower the acetylcholine needs to go down in order to balance the EPS effects. So keep that in mind if you see, and it shouldn't be, but you have a patient that's has Parkinson's and they have a low amount of dopamine. Sometimes you'll see people try to address the motor activity through the balancing of acetylcholine. So just kind of keep that in mind. For SGAs, I think I mentioned that you have primarily reduction of dopamine in the mesolimbic areas. So again, that's where the negative symptoms come from. And they reduce serotonin and reduce dopamine in the tuberoinfundibular, which again increases the prolactin. You get the sexual side effects. One of the things that you can think about in terms of when you're prescribing antipsychotics, first generation or second, is the way I think of it is the symptoms, and they're basically the way that you treat it is very much like how you would treat someone that's pregnant. So someone that's on antipsychotics, what you're going to look for is an increase in cholesterol, increase in weight gain, an engorgement of breast or gynecomastia, dysregulated menstrual hormonal cycles, changes in blood pressure, metabolic needs increase. In particular, glucose is going to increase. So it's very, very similar to what happens in pregnancy. And also, to sort of continue on with that analogy, when people are pregnant, they have to go periodically to check weights, labs, BMIs to make sure everything's going. That the baby is developing properly and the body is adjusting properly. Well, it's the same thing with antipsychotics. So you do baseline labs, you do baseline BMIs and weights, and then every 4, 8, 12 weeks after the initiation, and then quarterly after that. So even though it's a little bit more than what you would probably expect for a wellness, baby assessment, it is very similar in that you're going to have to continue to follow the exact same criteria in terms of labs, BMI and weight in the same way that you would for someone that's pregnant. And really that was the only thing that I wanted to sort of to highlight with this particular video is you're not going to see a lot of the traditional antipsychotics in outpatient. What you're going to see is going to be your second generations, which is your Risperidals, your quetiapines, your Zyprexes, Geodons, etc. And those are the ones that you're going to primarily want to focus on. I'm going to cover these very, very briefly because I think this is what you're going to see, like I said, more often. But a few things to know for your probably exam and for your certification regarding Risperidol is it's the only one that is FDA approved for adolescents and geriatrics. It reduces serotonin and dopamine by antagonizing the 5-HT2A and the D2 receptors. It has very little cholinergic effects, and it blocks alpha-1 and H1 receptors, resulting in orthostatic hypertension, sedation, appetite stimulation. So those are things you want to look for when prescribing Risperidol. But again, it is considered to be one of the more safer and probably one of the most clinically trialed and researched. So that's usually people's first choice. when you are beginning one of those. There is a pioperidone or Invega, which is essentially a chemical cousin to Risperdal. Has a little bit cleaner side effect profile. Doesn't tend to have as much effect on blood pressure. Not as sedating, and it doesn't stimulate appetite quite as much. But essentially, the side effect profile is the same as highlighted in your book and in the PowerPoints. Zyprexa. The interesting thing about that you need to know is you don't want to use this medication in people that already have weight problems, already have metabolic issues, because it tends to actually be the one that increases weight predominantly. It blocks serotonin and dopamine, much like Risperdal, but it has a high affinity for cholinergic, histaminergic, and alpha-1, and that's where the histamine in particular has a high affinity for that, is where you get the appetite stimulation from. It also normalizes NMDA receptor function, which downregulates glutamate, which is a good thing. It's one that's often used in bipolar augmentation, sometimes as a mono treatment, is because of this downregulation of glutamate. We'll talk about bipolar in one of the videos that's coming shortly. Geodon is one that I would consider if you do have someone that's in the situation that I described with Zyprexa, where they're already sort of overweight, they already have maybe appetite suppression issues. It's very much weight neutral. But the caveat with the Geodon is that your book is probably going to say that in addition to the other symptoms that follow along with second generation, it also has a tendency to increase or prolong rather the QT interval more often when compared to the other SGAs. Your QT interval is EKG. You really need to get an EKG before you start any type of antipsychotic, because all of them, like I said, can prolong the QT interval. Geodon tends to have a higher effect on those. A QT of interest, anything over about 430 to 450, you want to be very, very cautious when you're administering that. Anything really over 450, unless it is a critical sort of inpatient situation, you really don't need to start an antipsychotic. Anything over 500, you prescribe an antipsychotic, is actually going to be malpractice, because it's very likely you can precipitate torsades, which is going to kill the patient. So be very cautious. Just make sure that you know the EKG status, whether there's one on file before you start or initiate antipsychotics. Quetiapine is another one that's very popular. We use it a lot at the VA. I'm a personal fan of it. At the lower doses, 50 to 100, you get a little bit more of the for 50 to 100, it's often prescribed for sleep. So you may have someone that comes into your clinic that may be on 50 to 100 that are not psychotic. They're not bipolar, schizophrenic, etc. But it is a very good medication to kind of help sleep. When you see it in the higher doses, usually around 300, that usually means that there is some mood disorder that's being treated, in particular bipolar, or that it's being used for schizophrenia. One thing to note with Seroquel is just sort of a pearl. A lot of people that come in that request Seroquel, check their past history for substance abuse, because Seroquel actually does have some street value, and a lot of people come in requesting for Seroquel because they never can get it, and they sell it, and they use that money to go and buy drugs. The other thing is that in prison and now in the streets, there's a couple of rap songs about it that suggest that combining Seroquel and cocaine gets you a better high. They call that combination Susie Q's. So for me, if I have someone that has a pretty just sort of a pocked drug history that I'm kind of questioning whether or not they actually do have a real need for Seroquel, and they come in and ask for it. It is not my first medication. I usually will go to Risperdal if that's the case. But just keep that in mind. And you have Abilify, which was at one point in time considered to be a third-generation antipsychotic because it doesn't reduce dopamine outright in the way that the other ones do. It actually is a partial agonist, meaning that it only agonizes where dopamine is low. If dopamine happens to be too high, it actually will stabilize those areas. The thing about it is it's not as effective for acute psychosis. It's not as good for people that like I said, that are in an acute stage of schizophrenia. It's better as an augmenting agent once the psychosis has been stabilized. It's also a very good augmenting agent for people that have treatment-resistant depression and also that have bipolar. So you may see Abilify co-prescribed a lot for those diagnoses of interest.